Good morning, everyone, and welcome to today's webinar, Advanced Reproductive Age and Fertility. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. We have the email you registered with, so no need to do anything else. Harvard sends them out the certificates once a year in the summer, in late July or August, so check your emails around them for your certificates. Additionally, we encourage you to submit questions to Dr. Sneeringer using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. Now, without further ado, I would like to introduce today's speaker. Dr. Rita Sneeringer is double board certified in obstetrics and gynecology and reproductive endocrinology and infertility. She graduated with honors from Georgetown University School of Medicine, completed her internship and residency in OBGYN at the Harvard-affiliated Beth Israel Deaconess Medical Center, and her fellowship in reproductive endocrinology and infertility at Boston IVF and the Beth Israel Deaconess Medical Center. Dr. Sneeringer's primary clinical interest is the diagnosis and treatment of infertility and recurrent miscarriage. Dr. Sneeringer sees a wide spectrum of fertility patients, and she strongly believes in a personalized, evidence-based approach to fertility treatment. All right, let's get started. I'm going to pass it over to Dr. Sneeringer.
Good afternoon, everybody. It's very nice to be here, and I'm happy to talk to you today about a really important topic that I'm sure many of you also come across in your own practices, and I hope today I can give you some information about advanced reproductive age and fertility potential, and also some of the evaluation treatments that we focus on when we're having patients of advanced age. So I have a presentation today I want to go through with you, but I hope that you will ask some questions too, because I think that will probably be the most interesting part, is just answering the specific questions you might have, clinical questions and things from your own practices. So let me just get started by going over going over a little bit of the objectives, the kind of focuses that I have for the presentation today. So I'd like to go over with you, review and discuss some special considerations for the assessment of fertility in patients of advanced age, and also review the significant impact that advanced age has on fertility. This is probably the most important factor in terms of chances for success. The impacts clearly affect both pregnancy rates, treatment outcomes, including IVF outcomes, and the biggest issue with advanced age is the increased rate of aneuploidy in eggs of women that are older. I also want to talk to you a bit about preimplantation genetic testing for aneuploidy, which over the past 5 years has really become a really important tool that we've used particularly in this group of patients. And I'd like to go over with you how it's done and the success rates with it, and also which patients are really the best suited to have PGTA done. And then also finally like to talk to you about another treatment that is also very much utilized by patients of advanced age, which is of course donor egg. And again, I'd like to go over with you kind of how donor egg is done and how what the options are there and which patients it's best suited for, and answer, of course, any questions you have about that. So I think starting kind of with the definition of advanced age, because I think many of you are OBGYNs and there's some PCPs out there, and we have different definitions of advanced age. For the most part, it's not clearly defined and relevant to all areas of medicine, but really they're defined based on clinical parameters. So as you all, I'm sure, know, we usually call advanced maternal age greater than 35 years for obstetrics, and really that's based primarily on the risk of amniocentesis being equal to the risk of Down syndrome. So it's sort of arbitrary, but it is again based on some clinical information. So in reproductive endocrinology, we also use clinical parameters to define, hold on, what happened there? 1 second, sorry. I apologize. Let me just see what's going on here. Alyssa, any? Oh, there we go. Show my screen. And there we go. I think it should be good now. But in reproductive endocrinology, we also use clinical parameters to define advanced age. For us, it's really when fertility significantly declines and where we see a significant increase in the risk of aneuploidy. And so for us, for most, again, it's not absolutely clear, and it's sort of more of a general understanding of when these risks increase, but it's usually most people would look at 38 years old or older as being advanced age in the infertility realm. So this is actually an interesting study that was done many years ago, looking at several groups of people, several populations of people in several different. You can see down here the different groups that are in this graph, and also the years in which they were analyzed. But this was basically looking at natural fertility. So this is not fertility treatment in any way. It's natural fertility in several different populations of patients that do not use any contraception. And again, they're different decades, different centuries even, looking at these different groups, but it's really quite remarkable how close they really are. So this is the rate of pregnancy and birth, actually, it's the rate of birth per 1,000 wives. These are married couples not using any contraception. And you can see that the rate falls dramatically right in that timeline I was just talking to you about. So in the late 30s and into the 40s, it really plummets. And so this is where we get this idea of advanced age being related to when fertility is really declining significantly. You may have heard of the Hutterites. That's a group that there's a lot of population studies based on for natural fertility. So that's one of the groups that's in here. But the other groups are similarly, not confined populations where there is no contraception typically used in that group. So going on to, assessment of women of advanced age. So I think many of you know, but of course, I'm sure you're aware of ACOG guidelines. But in addition, we have the American Society of Reproductive Medicine also puts out guidelines for fertility assessment and all things RAI, basically. And both of these groups, recognizing the decline in fertility of women of advanced age, have recommended that we perform an evaluation for infertility on earlier for women who are over 35. So this is also very much in line with what many of the insurance guidelines are here in Massachusetts, which would also define infertility if it's been more than 6 months for women over 35, whereas the general definition otherwise for younger women is a year of trying to conceive. So again, this is where OBGYNs in particular can really play a role in making sure patients who have been trying to conceive for more than 6 months know to come in and get an assessment and figure out what's going on. And the other step, of course, is to make sure that you get into treatment as soon as possible. There are two main issues with patients that have advanced reproductive age. The two main issues are quantity and quality. And so a lot of the assessment that we can do is really ovarian reserve testing. And so we can really only assess the quantity question with the pre-cycle testing, the assessments done, with blood work and things. The quality is really much more associated with the quality of the eggs. And one of the biggest factors there, of course, is whether eggs are chromosomally normal. As women get older, there is a significantly increased risk of chromosomal aneuploidy in the eggs, which leads to abnormal embryos And that part of it is really not able to be assessed further with testing. We can get an idea of quality during treatment cycles, like just looking at the embryo quality. And if we've done PGT, we can certainly see the rate of chromosomal abnormality there. But it is, but in terms of a pre-assessment, in terms of a patient comes in to see you and wants to know, what's my fertility? I'm 37 years old. What's my fertility? You're really not going to be able to tell them much more about quality, except just based on what you know about quality at 37. So that one's a little tough because some patients really, it's hard for patients sometimes to understand that. So the assessment with the ovarian reserve, again, the quantity question. So the testing that we would typically do, and this would certainly be reasonable to do in your offices as well, would be hormonal assessment on day 3, so in the follicular phase. The mainstays there are an anti-Müllerian hormone, FSH, estradiol. There's also, sometimes you can do inhibin B is another one, and sometimes LH is another one. But the two that are probably the most important to know are the AMH and FSH. And you can't really assess the FSH well without the estradiol. So you need kind of both of those to assess, make sure you're doing the FSH at the right time. Of all of them, I would say the AMH is the most helpful in terms of predicting ovarian reserve, and also very, very helpful when patients are referred to fertility centers for further evaluation and treatment. The AMH is really the main thing that we look at in terms of doses and in terms of, you know, treatment plan and treatment protocol. That is probably it's certainly the most accurate measure of ovarian reserve. There is another study, I'm sure many of you have heard of this too, but there is another assessment that kind of incorporates all of those hormonal tests in one, which is called the Ovarian Assessment Report. And it basically is measuring all of those hormones, but also provides a assessment of what the likely number of eggs would be retrieved in an IVF cycle. So even if a patient isn't doing IVF, it can be helpful to get a better sense of what the response would be to stimulation. And the last test that we do for ovarian reserve is something called an antral follicle count. This is an ultrasound, a transvaginal ultrasound, where we look at the ovaries and we count how many of the little follicles are beginning to develop. They're not Graafian follicles yet, they haven't responded, but they're the group, it gets an idea of the cohort of follicles that are available. And you may or may not know, but you basically women are born with all the eggs they're going to have, and throughout life, you're constantly losing eggs. And the antral follicle count, each month, you have a group of eggs that are potential, that are possible to ovulate. And that group, that size of that cohort, slowly begins to decrease as you get older. A normal antral follicle count would be about 10 total, so 5 and 5, 7 and 3, whatever, but overall 10 or more antral follicles. But a young woman, it's not unusual to get closer to 20. And in a woman of advanced age, we often will see less than 10, but that is definitely helpful too in terms of predicting response and ovarian reserve. So the other part of this, as I mentioned, the other part of assessment is the quality side of things. And again, there's not another test that we can do in the office that will allow us to get a better sense for that individual patient what the quality is, but that we do have quite a lot of information on the rate of aneuploidy as it relates to age, and it is very strongly correlated there. So I want to share with you some of the data on that. And I think some of it you've probably seen before, but maybe not all of it. So aneuploidy, the main issues with that are an increased risk of infertility, an increased risk of miscarriage, and an increased risk of viable aneuploidy, which is like Down syndrome and that kind of thing. Trisomy 13 and 18, and also, so the rate of all of those things is really related to age. So the first, of course, is infertility. So this is kind of an interesting study that's done in the National Survey of Family Growth and the years that these are assessed. So a lot of the data I'm going to present to you today is from, you know, around this time, like 2015 to 2018, because it does take time for the CDC is the group that usually collates all this data. It takes time for them to assess and confirm, and also the fact that we're looking at births. It takes time for the women to have birth. So usually the data is lagging for a few years. So the most recent data is actually 2018. But this is from the National Survey of Family Growth. So it was determining among patients, these are not necessarily patients that are going to a fertility clinic or anything, but this is just among all women of reproductive age, which they defined as age 15 to 49. What percentage of them were seeking for infertility services? And so it gives us an idea of what the rate of infertility is among patients. Of course, I would assume that the actual rate of infertility is higher than what's reported here, because there probably are patients that haven't sought any infertility services. And you can see that it is remarkably increasing as you get older. And they also separated by patients who've had no children and patients who've had children. But you can see, of course, going from the youngest group at about 3% all the way up to the oldest group, which is, you know, over 20%. And similarly over here, they've had, you know, a significant increase with age. There's also, this is the miscarriage, a study looking at miscarriage rate as it correlates with maternal age. And you can see here that, you know, the rate of miscarriage in the late 20s really up to the early 30s is pretty low. It's about 10 to 15%, and begins to rise, you know, around 32, 33, but it's still pretty flat here. It's not like a super change between these years, but when you get into the late 30s, like 38, 39, you can see the slope of the curve here is really a lot higher, and there's a marked change in the rate of miscarriage. So when you're in the mid to later 40s, we're looking at over half of pregnancies that will end in miscarriage. And there is some data also suggesting that when you're in the 45 range, that it's probably over 90%. So it keeps going up here. And then finally, maternal age and aneuploidy. So this is the risks of trisomy 21, 18, 13, and how that is changing as you get older. And I think many of you are as familiar with this as I am, but of course, this is another consideration for patients seeking fertility care with advanced age. And you can see here, the late 30s is still reasonably low, you know, less than 1% risk of having a child with a viable aneuploidy. And then, of course, you know, when you get over 40, that we're really seeing a large rise. And the 1 in 60 is much closer to 40 than 44. So when you get up to about 44, then the risk of trisomy 21 is like 1 in 10. So it really does rise sharply, just as it did for the miscarriage. This last one, this time frame in the 40s is a very sharp rise year to year. So, you know, what can we do for patients with these two issues? So again, quantity and quality. The treatments for patients with advanced stage are generally more aggressive, and we generally go forward with IVF is very often considered the first line treatment, particularly for patients over 40. But even for those patients that are, you know, 38, 39, a lot of times I'm talking to them about the benefits of going to IVF. And the way I usually describe it is that a more aggressive approach is really needed because you have a short window here. It's not as if you're going to have a good chance to have a pregnancy and live birth for a very long time. And so with a shorter window, it is definitely, you know, advised to think about a more aggressive and higher efficacy treatment when they are younger. We can do pre-implantation genetic testing. can be done for embryo selection primarily, and it's really to identify those embryos that are chromosomally normal, to transfer those and reduce those risks we just talked about. And then donor egg treatment is usually recommended for patients that are over 44, and even some that are like 43 that have diminished ovarian reserve. For patients that have not been successful with IVF attempts, of course, the chance of that happening is greater as you get older, and with severe diminished ovarian reserve as well. And this donor egg can be used for young patients as well that have like premature ovarian insufficiency. But the vast majority of donor egg patients are usually have a combination of factors and are in the group of advanced reproductive age. So there's a bunch of data I'm going to show you now that are from the CDC and SART database. This is one from 2017, as I said. This was the second most recent report, but this just gives you an idea of the number of cycles that are being done in IVF among the patients having IVF cycles in the United States. There is a large proportion of them that are in patients of advanced reproductive age. So it ends up being about 40% total. And you can see that there's even a significant number in patients over 42 and 41 to 42. You know, so it's interesting to see how it's being utilized. So again, I'm going to be presenting a bunch of data now from the CDC and the Society for Assisted Reproductive Technology. I think many of you probably aren't aware, but most of the IVF centers in the United States report voluntarily to the CDC and SART all of their information in terms of efficacy of treatments, the different types of treatments that are being done, the different adjuncts like PGT. And all of this very detailed information is collected by the CDC and then confirmed, and the data is collated and everything, but it takes years to get the information out. And each year, though, the CDC does publish reports on the national statistics and clinic-based statistics as well for all of the United States and all of the clinics that are participating. The vast majority of clinics do participate. It's over 500 clinics. And last year there were over 330,000, I think, total cycles of ART. ART is assisted reproductive technologies, which includes IVF, donor egg treatments. It includes egg thaw, egg freeze, all of the kind of treatments that involve technology basically and fertility care. The compiled data is publicly available. You can go to the cdc.org and you can get, just go to ART and you'll be able to pull up the assisted reproductive technology reports. They're available to patients, they're available to providers. It is a nice way to kind of get a summary of what's going on in the infertility world. There's also, under the reproductive health area of the CDC, there's also information on infertility as well. So the ART is really just looking at the treatments and success and everything, but there is also some infertility information available by the CDC as well. They follow. So this again is the 2018 SART and CDC age and live birth statistics. This was the most recent data that is available right now. And these are the percentage of intended egg retrievals that result in live birth. So a lot of times you hear the statistic reported as per cycle, the chance of live birth per cycle start. So some of the patients may have had canceled cycles. They may have had, this would include all of those patients. They may not have had, you know, an embryo to transfer, that kind of thing, but it would include from a cycle start perspective what the chances are for a live birth. And these are patients using their own eggs. This is not donor egg. And you can see that the odds of live birth significantly decline as you get older. And these also, by the way, are fresh transfers, so it does not include PGT or frozen embryo which would automatically need to use frozen embryo transfer. So, but you can see it goes from about 50%, less than 35, the most optimal group, to, you know, somewhere around 30 to 40%, to just about 25% with the 38 to 40-year-olds. And then the over 40, it's going to be, and a lot of this depends on whether you're 40, 41, 42, but this is going to be, you know, probably in the 10% or less range per cycle start chance of a live birth. It's a significant decline. This is another statistic that was on the CDC website, which I thought was really interesting. This was looking at the number of cycles that were needed to achieve a live birth for different age groups. And as you can probably expect, this also changed significantly as you got older. So for most women that are in the optimal age group, most women are going to have a live birth within the first 2 cycles of IVF, which is not bad. Goes along very well with the 50% chance of live birth as well. It goes up to 2 to 3 cycles in the 35 to 37, 4 cycles or more, 4 or 5, between 38 and 40. And then this is I was surprised to see this myself actually, that the average number of cycles for someone over 40 to have a live birth was 13. So there's a lot of people doing a lot of cycles out there. This is probably my suspicion is that a lot of these are patients doing pre-implantation genetic testing cycles that that didn't get a normal embryo and kept trying until they got a normal embryo. This is a few years ago. This was 2010. This is again the same CDC data, but I didn't have an updated version of this, looking at patients, you know, over the course of ages. Just this kind of presentation I thought was really helpful to see. So these are again the IVF success rates. Pregnancy is in the top, and then we do see some miscarriages and things like that. So that's why the live birth rate pretty much follows that same curve, but it's lower. And then singleton live birth rate. So this was something that over the past 5-10 years has really been a push to try to improve the singleton live birth rate. I think if we had data from now, this would be a lot closer to the line of live births at this point. But you can see that there is a major drop. This looks kind of similar to that natural fertility curve we looked at earlier. There's a big drop in the chances for a live birth for women in their late 30s and certainly into the 40s. This is where we really see the curve dive down. And so, you know, all of this is very consistent with the natural fertility, with the rate of aneuploidy and all of that. And this is the more recent one. This is the 2017 report. And again, showing the drop in the chances for conceiving, but we're going to come back to this in a little bit, but this is with donor egg. It does stay pretty flat, a little bit up and down, but pretty flat despite older age, with still a very good chance of conceiving and having a baby with donor eggs. So this is again, own eggs, donor eggs. And then just one other study I wanted to go over with you. This is actually a study that we did at Boston IVF several years ago, but I do think the information is still very valid. We looked at patients, specifically focusing in on patients over 40, but looking at year to year and trying to see. So as you can see with a lot, oh, why is that doing that? Sorry about that. I'm not sure why that keeps doing that. As you can see from the prior graphs I've talked about, there is a big drop over 38, 39, and into the 40s. But a lot of the CDC data and things really only separates the groups. For a while, it was over 40. So that's a big group of patients, and it's hard to know what happens in the 40 to 45 range. Specifically, how much is it changing in those 5 years? And then more recently, they redefined the groups of for up to 40, 41 to 42, and then and then over 42. So we're getting more data in the more recent years, but this was a study that was done before we really had that. And again, we were looking in our own patients at Boston IVF, how many cycles were done in patients at least 40, but up to 46. As you can see, we clearly do a lot less cycles in the 45 to 46, and even 44 starting to decline significantly. But this is what I want you to look at, this last line here, which is the live births per cycle start. So that's that statistic I mentioned before. It means for a patient starting an IVF cycle with the intent for retrieval and the intent for transfer, how many of them, what percentage of them will have a live birth? And at 40, it was 13.9%. At 41, 9.7, 9.2. These were kind of surprisingly similar. It's more recent data, and other data would suggest it does decline here too. 7.6% at 43, and then it's down to really low chances, 2.6, 1.9 at 44 and 45. There's a lot of consistency in patients that are undergoing IVF treatment over 44, that the chances for live birth are usually between 1 and 2%. Definitely less than 5%. And for those of you that are in Massachusetts, the mandate for infertility coverage is really if you have a chance of at least 5% or more for a live birth. That's really what the threshold is for coverage. And so that is also why most of the insurance companies, not all, but most of them, do cut off treatment at 40. Once you turn 44, they do not cover for fertility services anymore. Again, very consistent data, but I think the main thing I wanted you to see here is just even in between the years in the 40s, there's a major decline year to year in the chances. So, what can we do about this? Well, certainly, as I mentioned before, patients coming in to be seen earlier in the process, patients coming in to be evaluated and to start treatment and to be a bit more aggressive are probably the best things that we can do in terms of optimizing chances for patients to have a good outcome. There are also some tools that we can use to help select for the best embryo, to move along the treatment as quickly as possible, to have a more efficient treatment. And the leading example of this is really preimplantation genetic testing, which has become very, very commonly used. The most recent statistics from the CDC were showing that it's probably about 1/3 to 40% of the cycles patients are using PGT along with their IVF treatment. And so it is definitely becoming more and more popular. It definitely was not that much even a few years ago, but we are using it more and more now. Picture here is actually how we do PGT. So in order to do preimplantation genetic testing, we do IVF, we create embryos, we culture the embryos out to the advanced stage. And it's important to know that there are, not all the embryos will fertilize, and not all the eggs will fertilize, not all the embryos will get to the advanced stage for biopsy. So it's usually a small portion of the total eggs retrieved will lead to embryos that can be biopsied. And that also is affected by age. So the older you are, the fewer embryos typically make it to biopsy. But once we do get them to the trophectoderm, to the blastocyst stage, then we do a biopsy on the trophectoderm. So this is a blastocyst. This is the inner cell mass, which is what becomes the baby. And then the trophectoderm, which is what will eventually become the placenta. And the reason that we do a trophectoderm biopsy is it is thought to be, and there's research showing that it is safer to do the biopsy here. It also allows us to get multiple cells. So in the past, PGT, many, many years ago, PGT was done on a day 3 embryo, which was about 8 cells or so. And it would take away one of the 8 cells, and they'd only have one embryo to assess, one cell to assess. And it was a little bit more risky taking away 1/8 of the embryo versus a few cells from the trophectoderm, again, the part that's going to be the placenta. So this This is the biopsy. I think if I can really give you one piece of information today, or if I can convince you of one thing, it would make me happy to know that I've convinced you that PGT is really not the best for everyone. Not everyone needs to do PGT. In fact, there are some very good studies that have been done that have suggested and shown that, particularly in young patients, it probably isn't helping at all. And I'll show you some of that data in just a few minutes. Older patients are really probably the prime patients to benefit. As we've seen in the prior slides, they are the ones that are the most likely to have chromosomal abnormalities. They are the ones that are most likely to have the clinical outcomes associated with that, like problems conceiving, lower chances of IVF success rate, higher risk of miscarriage, higher risk of Down syndrome or trisomy 13 or 18. And so they are the patients that are the most likely to benefit from having that pre-implantation diagnosis made as to whether or not the embryos are normal or not, and only transferring those that are normal. But not all older patients are necessarily good candidates for PGT. There are some additional considerations that we need to think about, including there are risks of doing the biopsy. As you can imagine looking at that picture, there is a possibility of damaging the embryo. There is a possibility when we go to thaw. So when we do PGT, we have to freeze the embryos, wait for the results to come back, and then only thaw and transfer those that are normal. And so, there is a risk of an embryo not surviving the thawing process as well, which is about a 5% risk. The risk of damage to the embryo is probably closer to like a 1% risk. It's not high. There's also a risk, which I didn't list on here, but there's also a risk that the testing could be wrong, that the result that we have would not really truly be an accurate result for that embryo. And in that's also very low risk, but there's no perfect test. And so, you need to take that into consideration as well. And so if you're a patient that has very, very few embryos that could be assessed, then it might make more sense to just transfer them and not take on these risks, because these small risks could be significant. If you have one embryo and you lose it in the thawing process, then you've lost any chance for a live birth with that particular cycle. The last thing, and I'm trying to make sure, kind of get you up to date on some of the insurance stuff as well, because a lot of your patients are going to ask about that. If you're talking about this with your patients in the office, just generally, you're going to want to know that for the most part, PGT is not a covered service. So there is significant cost associated with doing PGT too. And I think in the proper patient, it's worth it. But it is, that is something certainly the patients are going to want to know about, and it's certainly an important consideration as well. There's also, so I kind of mentioned this here, but it's patients that are not going to get a lot of embryos. This is what this is about. Maybe not the best to do pre-implantation genetic testing. So let me go through a little bit with you the STAR trial. So the STAR trial was done, I think it was 2000, let me see here, trying to remember the year. 2019 it was published. I think it was based on cycles from a little bit before that. But this was a randomized controlled trial. They had 661 patients that were randomized to either get pre-implantation genetic testing or to transfer embryos without freezing or thawing, transfer them fresh, and based on morphology alone. So morphology just means on the appearance of the embryos. That's our standard method prior to really using PGT. And the bottom line, the conclusion of this study was, in those patients that were less than 35 years old, there was no difference at all in the chance of a live birth. And so this is why I say that, PGT is not necessarily, the best thing for everyone. And I typically don't recommend it for patients that are good prognosis patients, first or second IVF cycle, less than 35 years. I almost never recommend it. I do have some patients requesting it, But I would almost never recommend it. The exception to that, of course, would be a patient who has a history of recurrent miscarriage and a patient who has like a translocation or something like that. That's not technically PGTA. That's actually called pre-implantation genetic testing for structural rearrangement. So that's a different category altogether. But in these patients that have either a defined or undefined cause of infertility, good prognosis patients, less than 35 years, it is probably not helpful to do PGT on them. This is sort of the data table from that same that STAR trial. And you can see here, so the control is the patients that had the embryos selected based on morphology assessment alone, and then the PGTA group. And as you can see, you know, the chances for live birth, actually this was, I'm sorry, ongoing pregnancy at 20 weeks gestational age, but usually those two parameters are very similar when followed through to live birth. And you can see it was 49% in the PGTA group and 53% in the control group, so very, very similar. There was a slight trend towards benefit in the older group, but this was really not powered to assess that completely. Most of the clinicians in reproductive endocrinology do believe that it is you know, further assessment in this group would have likely shown a benefit. And like I said before, usually we're thinking that the benefit is most likely to be in those patients that are in their later 30s. So that's just based on what we know about aneuploidy rates and things like that. So this is one of the vendors. So you may or may not know this as well, but when we do pre-implantation genetic testing, there are a few laboratories that do the actual PGT testing, and one of them is iGenomics, and this actually was taken from their website, but it is based on the 2016 SART or CDC data. So not only can you get the reports from the CDC SART, but you can request to get the hard data and do your own calculations and things. So this is kind of an interesting slide looking at, you know, the difference in the chances for implantation, which means basically pregnancy, miscarriage, and delivery per transfer for patients with and without pre-implantation genetic testing. And as you can see, the numbers, the two bars here are pretty similar in the younger groups. It becomes a lot different for all of these different parameters for the older patients. So those patients that had PGTA had a much higher implantation rate for the older patients. They had a lower miscarriage rate and a higher delivery rate. And it's really the most marked in the older patients here. Like the 40, you can see the 42 group is really, it's really pretty different. This was a study that was performed by another group that does a lot of the actual analysis, RMA New Jersey, which they looked at 15,000 trophectoderm biopsies and plotted, you know, the rate of aneuploidy. I think I cut this off by accident. This was, yeah, okay. So this is the percent of embryos which were aneuploid or abnormal. And again, all of these things are kind of very consistent, but this was the percentage of embryos that were abnormal, and you're getting up to the 90 percentiles up here of abnormal embryos, was significantly affected by age. So again, this sharp change in the curve, this sharp increase in the rate of aneuploidy was right around the late 30s. And it continued to rise exponentially into the 40s. And by the time you get up into like the mid 40s, the chances of having a chromosomally normal embryo were exceedingly low. In this same study, they looked at the chances of having no euploid blasts. So after testing multiple embryos, and some clinics actually do what's called batching. They'll do a couple IVF cycles and then collect, 4 or 5 embryos to test. And I'm not sure if they did that in this study. because we will, some of the statistics we see for the chances of getting a euploid normal blastocyst based on age is much higher than kind of what's reported here. Of getting a no normal embryo, is much higher. And so I think that very likely they probably collected embryos from multiple cycles and then assessed them. But anyway, the chances with those assessments of not being able to get at least one normal embryo was really pushing up to about 60% in the oldest group, and was significant for even these patients that were in this group. What I'm trying to say in terms of the way this study was done is that we see with our patients that are going through one cycle, maybe they have 2 or 3 embryos to biopsy, the chances of having a cancel cycle because there's no normal blastocyst is definitely higher than the 60% here for patients that are in the 42, 43 range. And then, I mentioned this a little bit earlier as well. The CDC, this is a 2017 report. Again, it wasn't reported in the 2018 one yet, but the PGT use is really increasing a lot. And you can see that it's not, so I do think that with the publication of the STAR trial and the evidence that it doesn't help patients under 35, I would not be surprised if we start to see less utilization of PGT in patients that are in the younger group. But it is, about a third of the cycles even in this youngest group. And we're seeing, it maximally in this group. And a lot of this may have to do with the fact that these older patients don't have a lot of embryos to test, and so they may have just deferred PGT because of that. But the most utilization was really in the 38 to 40 group. And I would say that, still pretty high in the 41 to 42 as well. Just a couple comments on where things may be going. So none of this is available really yet for prime time, but there's a lot of research into non-invasive forms of PGT-A, which would be looking at like the embryo media that we grow the embryos in and making correlations on trying to detect chromosomal problems with embryos, without having to biopsy them basically. And so probably not as accurate as the biopsy, but it could be another method kind of in between to help us select for better chance embryos that would not have the same kind of risks of the biopsy, and the cost and things like that would probably be significantly less as well. And so this could be like a middle of the road option for patients that either can't afford or don't want to do PGT because they have very few embryos, that kind of thing. And this would also probably be available not to have to freeze the embryos and wait eventually. So this is something coming down the line, but not really available yet. The EmbryoScope is also another way for embryo selection, and this is where we watch the embryos with basically time-lapse photography over the whole course of culturing them. So egg, embryo, this is as they go through here, and watching and getting to a better assessment on different time frames of when certain events happen, like cleavage and blastulation, and some of those things may be eventually correlated with better chance embryos. There's still a lot of research in the area. It's still not completely understood yet, but again, another area that may be helpful. And then there's a lot of research looking into increasing I wrote this wrong, but increasing the accuracy of results by trying to reduce mosaicism and using different technologies. Most of the companies now that do the testing is with next gen sequencing, which is a little bit more accurate than the earlier models. And then in terms of the idea of the things that we can do, are there supplements, medications, are there environments that produce better embryos? It's very limited, and there's either limited or no evidence supporting a lot of these interventions. One of the things that you may have heard of is like CoQ10 supplements. There is some limited evidence on CoQ10 improving egg quality and embryo quality, for example, but there's still a lot of potential in that area, but nothing really that's been proven, and nothing that we utilize for many patients. We do use CoQ10. A lot of us recommend CoQ10 supplements because the downside is really low. But again, it was still collecting information, those kind of things. The last thing I just want to go through with you quickly is just the donor egg option for patients with advanced reproductive age. I'm just going to go through a couple statistics with you and then open it up for questions. I do want to make sure that, what time is it here? Yeah, I want to make sure I leave time for questions here. So an overview, donor egg, there's two big options with donor egg treatment. One is a frozen egg bank, which means that donors have already donated their eggs and they exist in a bank. The advantages of the frozen egg bank is cost, it's a lower cost. It's a quicker time frame because the eggs exist already, and so it's usually like a 1 to 2 month process instead of like a 4 to 6 month process. Less likely to have extra frozen embryos because you're starting with fewer eggs typically, and there's a slightly lower chance of live birth per transfer, but it's still very good. It's still usually around 50% per cycle per transfer chance of a live birth. And then traditional egg donation is when a patient would select a donor, usually through an agency, and the donor would go through the pre-screening, the IVF process, donate the eggs, we fertilize the eggs, and you have a transfer without ever freezing the embryo. And that is a long process. It is more costly, but it is also the highest chances of live birth. And those most of the statistics around that are closer to 60% per cycle chance. So the utilization of donor egg, you can see here that approximately in the most recent data, approximately 20,000 donor egg recipient cycles or embryo transfers were done in the United States, which is a good number. Approximately 10,000, resulting in approximately 10,000 live births. And it accounts for just under 10% of the total ART cycles. So there is significant utilization of donor egg. These are the most recent, why is it doing that? These are the most recent statistics on success rates with donor egg. These are the different types of treatments that are done. This also includes donated embryos, but frozen embryos from donor egg, fresh embryos from frozen eggs, and fresh embryos from fresh eggs. So this is the traditional donor egg bank kind of treatments. And then these would be like the extra embryos that were frozen from those treatments. But you can see the numbers are very close to 50% for these, and then a little bit higher than 50% for the fresh cycles. And again, the main reason there is you're starting with more eggs, so you can be more selective about the embryos that get transferred back. This is the same chart that I had shown you earlier. And again, just highlighting the fact that even at advanced age, the chances for a live birth hold pretty much the same for patients, no matter what their age is. And then this is the most recent data from SART and CDC, the 2018, showing the number of cycles with fresh donor eggs, the chances of clinical live births, and also separating it into term, preterm, very preterm. So majority of them are term, majority are singleton. This is the green singleton. So this is fresh donor eggs. This is frozen donor eggs. So this is like the egg bank. Few more, this is probably the most commonly utilized now. This is the most cycles were done here. And then these were thawed embryos that were derived from donor eggs. And again, very high rate of singleton. Most of the vast majority are term births. So my last slide, and then hopefully I can do some questions. I think there's just a couple points I'd like you to walk away with. So first of all, advanced reproductive age is the most significant factor impacting treatment success. And I think it's really important to know how much it affects fertility. And older patients, and this is really where you would come in, older patients, and I would view older patients as, over 35, but really if they're getting into like the 38 range, then that's a little bit more urgent. Older patients should have an evaluation sooner, and I generally recommend more aggressive treatment options. And then PGD-A can improve the chance of live birth in some patients, but it's really not needed for all patients. There's really not good data suggesting it should be universally done. And lastly, donor egg treatment does have a very high chance of success, even in patients with advanced stage. So that is an option. Just to kind of get you informed, we generally, most clinics will do a treatment up to about age 50, but then, you know, arbitrarily we do stop it at that point for most patients. So, you know, if you're referring a patient that's 52, it's probably going to be pretty tough to get treatment. It could work. It's not a question of could it work. It's more of the other issues. So that's what I have in terms of presentation. I'm sorry I went a little longer than I expected, but I do think there might be a couple questions here, and I'm going to ask Alyssa if she could let me know. She's been monitoring the questions.
Yes, thanks, Dr. Sneeringer. We're going to now start to begin answering questions submitted during today's presentation. As a reminder, you still can submit a question to the questions pane in your attendee control panel. Dr. Sneeringer, our first question is, after how many miscarriages should we refer a patient? Is it 1, 2, 3, and is it also age dependent?
Yes, so good, very good question. So generally we would do, and it is a little bit on the earlier side, most of the research actually suggests 3, but we usually start a recurrent miscarriage evaluation after 2. So I think it would be perfectly reasonable if they've had 2 losses. If they're older, the reason is most likely going to be chromosomal abnormalities, but it is something that we would still do the same evaluation on a patient regardless of their age. But if everything came back normal, for the younger patient, we might start to dig even deeper. For the older patient, we'd probably presume it was aneuploidy related.
Great, thank you. With many people having children later in life, do you see a big jump or differences in egg quality in birth from like 36, 37, 38, 39 in those age ranges?
Yeah, so yes. So I would say, you know, the 36, 37, they usually are still doing okay. It's when you get over 38 that you really see that dive. And yes, it's pretty much a year-to-year huge difference in the chances. So definitely people are waiting later to start to try to conceive. And I think that's why we see so many more patients for infertility services to begin with. But certainly declines drastically in the late 30s in particular and on.
Thank you. I'm going to close it out just with the time we have right now. So thank you so much, Dr. Sneeringer, and thank you everyone for attending today's webinar, Advanced Reproductive Age and Fertility. If you have any other questions, please contact myself, Alyssa Cooper. My email is ecooper@bostonivf.com. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help us with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Sneeringer, thank you for joining us today and enjoy the rest of your day. Thank you, Dr. Sneeringer.
Thank you. Bye.